Good evening, everyone. My name is Kat Cook, and on behalf of the Orthopedic Institute at St. Elizabeth Healthcare, I'm excited to moderate this webinar about orthopedic services offered in Southeastern Indiana. And I'd like to welcome you to this educational event. The Orthopedic Institute at St. Elizabeth is a partnership between St. Elizabeth Healthcare, OrthoCincy Orthopaedics and Sports Medicine, and St. Elizabeth Physicians. The goal of the Orthopedic Institute is to improve the care and delivery of musculoskeletal medicine by focusing on quality outcomes, efficiency, and patient satisfaction. Before we start, let's get familiar with the webinar control panel, which is located at the bottom of your screen. Questions may be submitted throughout the webinar using the Q&A bubble located on the control panel. If it's not open, move your cursor to the bottom of the screen for the control panel to appear, and then click the Q&A button. A screen will appear to prompt you to submit your question. This is also where you can alert us if we are having any technical difficulties on your end. We would be happy to help you if you come across any of those. This webinar is being recorded and will be posted for later reference as well. Now let's get started. I'm pleased to introduce Dr. Brian Wissel, orthopedic surgeon from OrthoCincy Orthopaedics and Sports Medicine. Dr. Wissel specializes in arthroplasty, fracture care, hand injuries, general orthopedics, and sports medicine. Dr. Wissel is joined by Dr. Ronald Auer from OrthoCincy Orthopaedics and Sports Medicine. Dr. Auer specializes in arthroscopy, total joint replacement, and general orthopedics. Our physicians are also joined by physical therapist Colleen Kirkendall. Colleen is the manager of rehabilitation services at St. Elizabeth Dearborn. Thank you all for being here, and our presentation will now begin.
Good evening. I'm Dr. Brian Wissel, and I'm going to talk to you about the sports medicine and arthroscopic surgery experience at St. Elizabeth Dearborn, some of the services that we provide. First, I'll tell you a little bit about myself. I grew up on the west side of Cincinnati, so I'm a local guy. Went to the University of Cincinnati for both undergraduate and medical school, and then went about 100 miles west to Indianapolis for a 5-year orthopedic surgery residency at IU. And then I went down south for a year for a sports medicine fellowship, working with the Saints and the Pelicans down in New Orleans, as well as some of the local high school and college teams down there. As you can see here, some of my experiences in the sporting world, had some unique ones in the course of my training. In residency in Indianapolis, I had a chance to work with the guys that provided the coverage for the Colts. And so I had a chance to go into the locker room and do injury checks throughout the season. And then with the NFL Combine always being in Indianapolis, had a chance to go 3 years there and see some of the up-and-coming college players prior to the draft at the NFL Combine, doing player physicals for them. Then when I went down to New Orleans, had another couple of unique experiences working with college basketball teams down there, and then working with the NFL's New Orleans Saints, as well as the NBA's New Orleans Pelicans, seeing the care of the athlete, both from the surgical side, as well as from the kind of player management and the non-operative side. And so a big thing kind of backing up as far as sports medicine, some people are a little bit unclear as to what that is. It's kind of a catch-all phrase. And I think in the most basic sense, you see kind of a definition here, but it's really caring for athletes through the course of their careers. And not just, use the term athletes. It's not professional athletes. It can be weekend warriors. It can be people that, just kind of enjoy getting out of the house and working out and being outdoors. A lot of times it's things from sprains and strains and soft tissue injuries, but sometimes it can even be fractures, and sometimes it can be sort of chronic issues that are the result of a lifetime of being out and being active. And so you see here some of the commonly treated conditions. Again, accidents are inevitable, and so we'll see trauma and fractures. We'll see joint dislocations, see ligament injuries, tendon injuries. And again, these range from sprains and strains to complete tears. And of course, the treatment can be a little bit different for all of these, as well as a lot of overuse injuries. And naturally then, kind of segueing from the previous slide, some of the surgeries that we do, the big thing that people think about when they think about sports medicine is arthroscopic surgery, or minimally invasive. And that entails usually kind of little poke holes around the joint of interest, and then using a camera and small tools to access that joint. And there's quite a bit that we can do these days using just those couple poke holes. And so recovery is a lot quicker for patients. They don't end up generally with a big scar, and we are still every bit as effective as we were when we were making the big incision. And so the most commonly scoped joints for me would be knees and shoulders, but we certainly have the ability to scope wrists, to scope ankles, to scope hips. And so you'll see some of the other procedures we do. There's a lot of soft tissue fixation, whether that's Achilles tendon injuries, if that's ACL injuries, if that's rotator cuff injuries. And then sort of the end game, a lot of times when a joint starts to wear out from a lifetime of athletic activity, you start to talk about joint replacement and sort of managing an arthritic joint, and that involves injections. Another big part of the sports medicine program that we have out at St. Elizabeth Dearborn, and often goes hand in hand with a lot of sports medicine programs, is providing coverage for local high schools. It's something I enjoy doing, primarily during the football season, get out on Friday nights and get to provide sideline medical coverage. So we have agreements with a number of high schools in the area. That includes Milan High School, Switzerland County, as well as Rising Sun and South Ripley. There's a number of other high schools in the area, not on this list, and I've seen athletes from all of them. And we're always happy to see the local high school athletes who have a chronic issue or have a new injury and they want to be seen locally, potentially even have their surgery or have their therapy done locally. We always welcome you to call and get an appointment, and we try to get our athletes in, particularly during the season, within a day or two, because we know how important it is for you to get out there and to really minimize the amount of time that you're missing. And so it can be a little bit intimidating if you're looking at this and you're athletic glory days are a bit behind you, or you don't really consider yourself a big-time athlete and you think, am I in the right spot? Again, sports medicine is this catch-all phrase. And so if you're out at all being active and, you have an injury or you've got a chronic issue that just isn't letting you perform to the top of your ability, or something that's bothering you, you're kind of lumped into this. Some of the things that I've seen that people may not classically think, hey, this is a sports medicine injury. Things like water skiing, a lot of snow skiing injuries, particularly this past winter was an active one. But things like getting out golfing, playing pickup sports, a big thing that I see, very seasonal, was hunting injuries, as well as ATV accidents as the weather gets nicer. These are the kind of the services we provide. This is a little bit of what sports medicine is. And, you might be sitting back thinking, this makes sense. This is kind of me, or I'm interested. Where do we get the ball rolling with this? The biggest thing is it always starts with an office visit. Like, most experiences with your doctor, you got to call and be seen. It starts with a thorough physical exam. We kind of talk about what's been going on and kind of what next steps are. And the big thing I would emphasize is a lot of times these are things that we try to treat non-operatively. It starts with physical therapy, as Colleen will talk to you about. There's things we do in the office, whether that is just giving you some exercises to do at home, or if sometimes we talk to you about injections, and we're able to do all this stuff in the office. Injections will be steroid injections. Sometimes we talk about gel injections, and then sometimes we even talk about PRP injections or stem cell injections when that's appropriate. We also have all of our braces and durable medical equipment in the office. So we have boots, we have splints, we have casts, we've got braces. And so that's generally something that we can provide to you that day if we think it would be beneficial for you. Certainly, as much as we try to treat you non-operatively when appropriate, there's times where we have to dig a little bit deeper and we try to get an MRI. We have the ability to do that at the hospital at St. Elizabeth Dearborn. We generally go through your insurance, and once we get the green light for that, we'll get it done. And I have those images available to me right away, and we'll sit down and we'll go through it and talk about the treatment based on what that MRI shows. In some cases, again, surgery is necessary, and when it comes to that, we talk about it, but we're able to do the surgery at the hospital there at St. Elizabeth Dearborn. So to emphasize, I'm always happy to see you here and happy to provide care here in your community. You don't have to travel across state lines. We've got high-level care for you here in Southeast Indiana. So please give us a call and come up and see us, and we'll talk about what's ailing you, whether, again, that's a new injury or something that just isn't quite going away for you. But again, I'm Dr. Brian Wissel, and please give me a call.
Hello. My name is Ron Auer, and I'm an orthopedic surgeon, and I'm here to talk to you about hip arthritis and hip replacement surgery. A little bit of personal background. I went to the University of Cincinnati for medical school and to the University of Louisville for my residency training in orthopedics. What is arthritis? Arthritis is a combination of two Greek words, arthro and itis, meaning joint inflammation. It affects approximately 60 million people in 2020 and is one of the most common reasons to have a joint replacement surgery. Osteoarthritis is a little bit more common in ladies and in African Americans, Hispanics, more so than Caucasians, but it affects all of us equally. The rate unfortunately goes up as we get older, And the most common location to have arthritis is in the bottom of the thumb. The knee and the hip are close behind because they become the most symptomatic because they are the weight-bearing joints of our body and how we get around. As you can see by this slide, 20% of the population is affected by this, and it's only going up. As that curve goes up, more and more folks are coming in to see us, orthopedic surgeons, for their arthritis pain and for their knee pain and hip pain. Arthritis sometimes is commonly called a wear and tear problem. Unfortunately, it's more likely a failure of repair. You undergo chronic injury through life's everyday activities, running, jumping, playing, or even trying to go up and down stairs. Unfortunately, as we use our body, we are unable to repair it as we get older or have other issues going on in our health. So that's why it's more common as we age. Symptoms can come and go. They can get worse with the days. Sometimes you'll have no pain at all. Other times, it'll generally get worse over time. One of the most common causes of joint pain is arthritis, and that arthritis is a generic term. It could mean anything such as osteoarthritis, rheumatoid arthritis, post-traumatic arthritis, which is when you break something long ago and then unfortunately get arthritis after that fracture. And then avascular necrosis, an uncommon but severe disease where blood flow is stopped in the bone and then the bone breaks down quite severely, causing very bad pain and disability. In this picture, you can see an arthritic hip versus a normal hip, where the cartilage has been wore out in the ball and socket joint of a hip. So we've gone over what arthritis is. I'd like to talk about some of the options. First off, we usually are seeing folks for different areas of pain. Sometimes they'll describe groin pain, upper thigh pain, even pain in the buttock. Sometimes it's a range of motion issue with stiffness and inability to turn the foot inward or outward. Sometimes it's difficult to put on shoes and socks or getting up from a chair and getting in and out of a car. Sometimes knee pain can even mimic hip pain because it involves the same bone, the femur. Pain is usually worse in cold weather or weather changes, and middle-aged patients can see it as well. The differential diagnosis, things that we're looking for, range from injury to arthritis to tendinitis or bursitis. And this is when you come to see us, the orthopedic surgeon, to diagnose one of the many causes of hip or knee pain. And we do a thorough history, examination, and may need to do testing such as x-rays or MRIs. Here's an example of a hip x-ray. You can see the normal joint space between the ball and the socket, and that's a normal picture of a hip. On the other side, a arthritic hip shows the narrow joint space, the bone spurs on the outside part of the ball and socket. This would be considered a moderate hip. They obviously get worse, and sometimes they're not as noticeable. We'll talk about some of the conservative treatment options and what we can do for hip arthritis or knee arthritis. The first is prevention. Keep your weight at a healthy level. Try to keep your BMI at the recommended levels. This decreases your risk of osteoarthritis. Avoid smoking, which weakens the bones, and then the bones have a failure of healing and are unable to repair, as we talked about earlier. Also, to control inflammatory arthritis, such as rheumatoid, lupus, and gout, which can damage the inside of the joint, causing more arthritis. Also, if you have had a injury, to have that corrected and to realign the body or realign the bones to create a better alignment so that your body works more efficiently. This can include repairs of previous tears, such as the ACL, meniscus, or if you had a previous fracture. Some of the treatment options, a little bit more aggressive, would be to decrease your activity, to take medications, whether it's over-the-counter anti-inflammatories or prescription-strength anti-inflammatories. Injections are something that I perform on a daily basis, such as steroids or what we call gel shots, which we'll talk about a little bit. And physical therapy can help strengthen the joints. Home exercises can help keep you nice and stretched out, limber. And some of the other issues that we come across are surgery when it gets bad enough. Activity modification is not a popular choice because we want to live our lives, get out there, be active. We don't want to sit on the sidelines and not enjoy life. Surgery might be the only option. Typically, that is when the pain is so severe that you can't function with your activities of daily living. These could be as simple as putting your shoes and socks on, or going up and down stairs, or getting in and out of your car. It may be even more intense activity like exercising or walking or hiking. If it interferes with your work, this is another reason a lot of people come to see us, is that it is starting to hurt every day at work, or maybe even affecting your work. And also, if you've tried everything else, if you've tried the injections, you've tried the medications, and you're dealing with their side effects, or you've tried weight loss, and you've tried every other possible method to get rid of this pain, and you're looking for more aggressive treatment options. When that becomes the issue, we usually look towards total joint replacement, or a total joint arthroplasty. There are millions of knee replacements and hip replacements that are out there right now in the world that have been performed since the late 80s. And nowadays, as you can see in this data, it's a little bit old, 600,000 total knee replacements were done in 2010. That has increased up to 800,000 in 2019, and it's only going up. Total hip replacements are right behind at about 300,000 a year. The hip implants are quite variable. When we talk about implants, we're talking about metal implants that go into the bone so that the bone can then heal to the metal and become one with you. We talk about replacing the ball and the socket, and these are some examples. There are many different types. This is the most common type that you'll see here, with a metallic shell, a plastic insert, and a metal head. More and more doctors now are using ceramic heads because of the longevity of that implant. The femoral stem that you see here is a very common stem, and many companies and doctors use this exact implant or something very similar to it. Other options include a ceramic on ceramic hip implant. This is a little bit less common, but gained popularity in the 2000s and represents another example of variation. You can see the difference between an arthritic hip, a normal hip, and the replaced hip. The goal is to mimic the normal anatomy. The hip replacement very nicely mimics the normal anatomy with the ball and socket, and where the metal is implanted into the bone and where the motion occurs. In a replaced hip, you can see the implant here where the socket goes into the pelvic bone, and then the femur is where we place the stem. Here's an example of an x-ray. This is a very well-placed hip replacement where you see the socket and the metallic implant of the socket in the pelvic bone, and the stem going down through the hollow or the marrow of the bone, and then that is where the bone grows into the metal, and then the metallic ball that sits in the socket. So what can you expect after your joint replacement? Nowadays, more and more folks are doing same-day total joint replacements, whether that's hip, knee, partial knee, or shoulder replacement. People are able to go home the same day, that's the same day of surgery, or with a simple one night overnight. It's not for everybody, but it is definitely more common as the years have gone on, as we've become better at doing the surgery, and also people are more aware of how to treat the pain. The majority of the people go home with family. It's very uncommon nowadays to go to a nursing home or rehab. Most of the therapy is done at home and then eventually with outpatient therapy. With a hip replacement, the first week you may be using a walker depending on your strength, and after a second week we do a skin check, removes the stitches or staples, and usually get folks to the cane intermittently in those first 2 to 3 weeks, and by a fourth week hopefully people are using the cane or the walker only in unsteady situations and the cane intermittently. By the fourth and sixth week, people are doing a lot better. They're walking faster, they have better range of motion, and their pain is noticeably better. At the 2 to 3 month mark, usually we see you again, get another x-ray, verify healing, and most folks describe near complete recovery at that point with some intermittent weakness or pain. By 9 to 12 months, people are doing far better than they were before surgery and have noticed sometimes they even forget which hip that was done. This is an example of the different types of approaches to the hip. These lines, the blue and yellow line, represent the most common approaches. The yellow line is the anterior approach, which is the approach that I perform and is becoming a more commonly used approach these days. The goal of the total hip replacement is to recreate the normal anatomy, and I feel as though that is performed best with an anterior approach where we cut no muscles and we're able to perform intraoperative x-rays while we're doing the procedure to get the leg lengths and the center of rotation and all of the intricacies of the mechanical alignment perfect for the hip. This is an example of the contraption that we place people on. It helps us hold the hip in a perfect location and to do the procedure safely. I believe that the benefits of the anterior approach, which have been well described in the literature, is a decreased risk of dislocations. This used to be one of the most common reasons for a redo or a revision total hip replacement. Now we have decreased the rate of dislocations to very low, less than 1%. It is a faster recovery. People are able to get up and walk quicker, faster, and get off the cane faster than they would with other approaches. It has increased our ability for a same-day surgery. Because people are able to get up faster, use a cane or a walker quicker, they're able to go home the same day of surgery. During surgery, we use intraoperative x-rays to measure the leg lengths. This helps us get that hip in a perfect position, to get the sizes perfect, and to make sure that we match the anatomy anatomically. The incision is smaller, and although it is mainly a cosmetic reason to do the surgery for this incision, sometimes people feel is that the smaller incision would be a reason to do that. The smaller incision does help cut down on blood loss and is also more preferred for most people. There's also no permanent or temporary restrictions. You may have heard in the past where people were unable to cross their legs or to put their feet in certain positions, or even to get down low on a load-setting toilet seat or a chair. This is no longer a temporary or even a permanent restriction. People can do as much or as little as they'd like to. These are some of the things that are to consider with hip replacements and hip replacement surgery. The faster recovery is made possible by both the anterior approach and some of the better implants we have nowadays, but also because of our hardworking physical therapists that help get people up same day from surgery and get them on the road to recovery so they can get back to some of the things that they love and want to do. And to talk a little bit more about that is Colleen, who will talk to you about the physical therapy and some of the services offered at Dearborn.
Hello, my name is Colleen Kirkendall, and I'm a physical therapist with St. Elizabeth Dearborn. I've been in the field of physical therapy for 30 years and have worked the past 22 years of my professional career at the Dearborn Hospital location. There, we have a highly skilled staff of therapists who are experienced in orthopedics to provide a wide variety of services to all musculoskeletal injuries. We also provide sports medicine injury prevention. We see patients with vestibular balance problems, and we have therapists who are specialized in areas of pediatrics, hand therapy, and neurologic conditions such as Parkinson's and stroke recovery. We work collaboratively with the surgeons of OrthoCincy and most closely with Dr. Auer, Dr. Wissel, and Dr. Trimba at the Dearborn Hospital location. It is through this partnership that we are able to offer our patients a seamless continuum of care. St. Elizabeth Dearborn is the leading provider of rehab services in Southeast Indiana. We have 4 convenient locations to serve your rehab needs. At the main hospital campus, we offer physical therapy, occupational therapy, and speech therapy. And we have 3 satellite offices that provide physical therapy services. Our hours of operation are Monday through Friday, with both day and evening hours to suit your convenience. During this webinar, I am going to present to you an overview of the utilization of physical therapy for patients with osteoarthritis, as well as joint replacement surgery. The goal of therapy is to help the patients reduce pain, restore function, improve their mobility and strength, and prevent and minimize disabilities. Physical therapy may be prescribed by your doctor prior to surgery in an attempt to delay the time frame for need of surgery. So in those circumstances, a patient with minimal to moderate osteoarthritis will work closely with a therapist to learn joint protection strategies to preserve the remaining cartilage of the joint. We will teach the patient how to improve their joint motion and strength, as well as maximize the safety of their mobility. And for later, when surgery is warranted, the patients will be ahead of the game in regards to their strength and range of motion. And they will have better outcomes after surgery because they'll be ahead of the game. Once a joint replacement is performed, physical therapy services begin immediately. You will be evaluated by a physical therapist the same day as your surgery. At that time, the physical therapist will work with the patient to show them post-operative precautions. For instance, for total shoulder replacement, and depending on the approach of your total hip replacement, you will have dislocation precautions. These are movements that we want you to avoid post-operatively to minimize the risk of dislocation. Total knee replacements do not have dislocation precautions. The physical therapist will also at that time give the patient an initiation of a home exercise program so the patient can feel safe and confident starting their recovery post-operatively. The physical therapist will show the patient how to safely get in and out of bed, how to stand up from a chair safely, and for our total hip and total knee replacement patients, teach them how to walk safely with a walker. Most patients after surgery will be on a walker anywhere from 2 to 3 weeks, sometimes 4 weeks, depending on the level of their post-operative swelling, their post-operative pain, and the safety of how they're moving around. When the patient leaves the hospital, they will have a clear understanding of the physical therapy course once they're discharged. For total knee replacements, we want to get them into outpatient therapy immediately. Sometimes patients may require home health PT, though, prior to initiating outpatient PT. Those circumstances would be for somebody who doesn't have transportation to and from outpatient therapy, or they're not moving as well as they anticipated, and leaving the home would be a hardship. In those circumstances, the patient would receive home health physical therapy for 1 to 2 weeks, and then transition to outpatient therapy. For the total hip replacements that are elective, usually no post-operative therapy is required once they leave the hospital. They would simply perform the home exercises provided to them by the therapist and continue to increase their walking frequency and duration each day. Once they have their follow-up appointment with the surgeon, approximately 2 weeks once they return home, the determination for need of outpatient physical therapy can be made at that time. For non-elective total hip replacements, that would be for a patient who has a hip replacement that didn't plan on it, such as a patient who falls and fractures their hip, they may require physical therapy immediately upon discharge because they have premorbid conditions of weakness and walking safety issues that led to the fall. Those individuals may require a short stay at a nursing home for skilled care, or they may be able to return home with home health or outpatient therapy, and the therapist at the time that they're being evaluated will determine which path is best for them. For total shoulder replacement patients, they will not start physical therapy immediately in outpatient. They will continue with a home exercise program provided to them by the therapist, which usually entails just some simple movements of elbow, wrist, and hand range of motion. And then when they have their follow-up appointment, about 2 weeks after returning home, the doctor will guide them on when to start outpatient therapy. For total knee and non-elective total hip replacements, the average duration of physical therapy is 4 to 6 weeks with a frequency of 2 to 3 times per week. Our treatment focus at that time continues to be on improving range of motion, especially for knee replacement patients. We want them to get their knee as straight as possible as soon as possible and also get good functional bending. Our bodies heal themselves with scar tissue following a surgery, and scar tissue is a little thicker and less flexible than our normal tissue. So in the weeks following surgery, it is imperative that the patient perform physical therapy services to get the best outcome in their range. We will continue to work with the patient also on improving their extremity strength and transition them from a walker to a cane to no assistive device if it's safe enough to do so. For our total shoulder replacements, once they begin the outpatient therapy course, the average duration of therapy is a little bit longer. It's 8 to 10 weeks in duration at a frequency of 2 times per week. Patients are usually in a sling for 3 to 6 weeks to protect the shoulder repair. The initial 6 weeks of rehab focuses on improving the range of motion of the shoulder joint per your surgeon's postoperative guidelines. And it is until about 6 to 8 weeks postoperatively when strength training usually occurs. It's important to remember that improvement in function can continue for up to 2 years following surgery. Successful results following a joint replacement depend on patient compliance with rehab. For the patient to get the most out of their joint replacement recovery, we want to improve their range of motion, strength, and safety with their mobility. And the patient should take comfort in knowing that the surgeon and therapist at St. Elizabeth Dearborn will work closely together to help guide the patient through the pre- and post-operative process. On behalf of St. Elizabeth Healthcare and OrthoCincy Orthopaedics and Sports Medicine, thank you for attending this webinar.
All right, this will now start the question and answer portion of our webinar. As a reminder, just submit your questions to the Q&A bubble, and we will be happy to answer them. So Colleen, the first question is for you. Is it helpful to do physical therapy before surgery?
Yes, it's beneficial to attend physical therapy prior to surgery. It may just warrant a few visits to evaluate the patient and determine what their limitations are at that time. So if they have restrictions in motion, we'll help them to improve their flexibility. If they present with weakness, we will help them to strengthen the limb. And by improving their strength and range of motion, they'll be ahead of the game post-operatively.
Dr. Auer, we have a question for you. How do you determine same-day replacement versus overnight?
A lot of it is determined based on the patient themselves. A lot of factors go into it, such as age, living situation. If there's a lot of help at home, people can get home on a same-day surgery. It depends also on how they're feeling after surgery, if pain's well controlled, if some of the other milestone markers are met immediately after surgery. And some people through the course of the day choose not to stay because they're not feeling well, or if they've had a headache or something. Some people will elect to stay, but usually we try to give people a heads up as to whether or not they are a candidate, and about 3/4 of patients are good candidates for same-day total joint replacement.
Okay, Dr. Wissel, this question is for you. Why would my student athlete need to see you?
Yeah, so that's a good question. There's the obvious one, if you're practicing or you're in a game and you have an acute injury, you twist your knee, you twist your ankle, you're unable to continue participating. Obviously, that's an issue if you're in mid-season and every day you miss is a day of practice or a day of participation in games. That is a big deal in a finite season. And so, the obvious acute injuries, but then also you sort of, as the season wears on, you get your chronic injuries that will prevent you from being able to participate, whether it's, the shoulders barking at you if you're a baseball player, or, you're having that chronic knee pain that really prevents you from being able to perform to the best of your ability. I find athletes are pretty good at triaging to the point where they know that this is going to become an issue that, it's hindering me from doing what I need to do. And so, again, when I find that athletes, when it gets to the point where you're going to miss time or you're not performing up to your expectations for yourself, that's a great reason to come see us and figure out if it's something that we can, generally start with something non-operative if you're mid-season and try to get you back and allow you to participate and ride out the season. And then if it's a bigger issue, that is something where in the off season requires surgery, we can get you back and take advantage of that time down in the off season anyways, and then get you back ready for the next season. So.
And Dr. Auer, Another question for you. How long does a joint replacement last?
That's a good question. Nowadays, with the modern implants and typically using a ceramic and plastic and the types of metal that are used now, we can pretty easily say it should last 20 years or more. That is quite variable based on the age of the patient, how active they are, body habitus. But in general, we like to quote about 20 years of reliable data. And that seems to hold true. But again, different factors go into that.
Colleen, I believe this question is for you. Does St. Elizabeth Dearborn still offer joint camp?
Right now, we're in the process of getting that started back up. On the last meeting that I attended, it looks like the in-person joint camp may not happen until fall due to the COVID pandemic. They currently have joint camp videos on the St. Elizabeth website that you can go to that will show a therapist doing the pre-op joint camp for the total hip, the total knee, and the total shoulder replacement. We can provide the links for those services.
So Dr. Wissel and Auer, this is a question for both of you. How is pain controlled after surgery?
Sure. So a lot of it is, again, patient-specific factors. I mean, generally, depending on the magnitude of the surgery, will dictate a lot of that. Obviously, the smaller surgeries, a lot of times you try to minimize narcotic use with just with everything going on in the world, and as dependence becomes a bigger and bigger concern. However, a lot of surgeries will just require that. They're painful for several days to a week afterwards, and usually we're kind of sparing with narcotics to give you just enough to make you comfortable. And there's a lot of surgeries where you'll have inflammation afterwards, and so I think anti-inflammatories play an important role in that as well, and that's your ibuprofen or your naproxen. And I'll let Dr. Auer talk a little bit more. And some of the big thing with joint replacement is like multimodal, so there's different medicines used. So you take anti-inflammatories, there's narcotics, there's even things like ice, elevation, and then sometimes there's even nerve pills, something like gabapentin. And a lot of it's an individualized discussion with patients. Different patients have different pain tolerances, and some patients come into surgery already having been taking pain medicine for a while, and so their body may require a little bit more, and that's always almost an individualized consideration with each patient.
That's exactly right. I think after surgery, once you're home, those are we're somewhat limited on some of the modalities. It's typically medications or some other things you can do at home. Immediately after surgery, many of our surgeries, we try to use local anesthetic, so numbing medicine to prolong the pain relief. Some people call them nerve blocks, to where you're either completely numb or partially numb to take some of that initial pain immediately after surgery away. That also helps with therapy. And Colleen knows about that if you're in less pain, they typically can work you a little harder, or maybe they can get more motion to improve your outcome after one of our more major surgeries.
Yes, absolutely. Pain control just helps to improve the patient tolerance to the necessary exercises that they have to do after surgery to get the maximal benefit and outcome of the range, strength, and return to function. In therapy, we can use modalities such as ice, electrical stim, moist heat to help augment pain control with the medications that the surgeons just mentioned.
And Colleen, this is another question for you. Do all surgeries require physical therapy?
I would be biased to that. I wouldn't say all do. Majority will benefit from it. And depending on the surgery, it may just be 1 or 2 visits to show them a few exercises of how to progress themselves post-operatively. Knee scopes require very minimal therapy intervention. They seem to do very well with just a simple home exercise program. However, your more involved surgeries like joint replacements absolutely benefit from physical therapy post-operatively.
I think it's worth noting that on many of our surgeries, they are Some of them are quite involved, such as a knee replacement or a ligament reconstruction like an ACL. And some folks with work schedules or financial situation, insurances, what's great about the therapy at Dearborn is that we can work with you and they can try to get you teed up for a home therapy so that maybe you don't have to spend so many visits. They're very good at giving you instructions at home, and a lot of our patients talk about how well they're instructed. They feel like they have good education, that they can get through the week, do their exercises, and maybe only need 1 or 2 days a week of therapy if that's how their schedule fits. I think it's been very helpful, and I've seen a great improvement in the outcomes of the patients that I've done surgery on.
Thank you. And Dr. Wissel, this is another question for you. If someone is an active runner, why would they need to see you? Why would they need to come see you? If they're having aches or pains, or is it a preventative practice? What would you recommend?
Sure. Yeah, the runners I find tend to be a different breed. They're very gung-ho. They've got their routine. They've got their miles that they will hit each week. And obviously, if it's a preventative deal, there's not a lot. I'm always happy to give sort of standard exercises and general maintenance that you incorporate with your running routine. I think they say an ounce of prevention is worth a pound of cure. You do these exercises and you try to prevent major injuries just by keeping yourself limber, by keeping your general core muscles strong, and that goes a long way. But then, of course, again, runners, like I said, they've got their goals and they're very regimented, and so if they get to the point where their performance is hindered, they're not able to run what they used to, or they're having pain or aches every time they run, I think that's always a good time to come and make sure that you're not making something worse, at least. And if we can, make it pain-free, whether that's an injection, if we're talking about having to do imaging to make sure there's not something more serious going on. I think always if you're noting a decline in your ability to run, that's a good reason to come be checked out.
And Dr. Auer, I've heard that sometimes when you have back pain, it's actually from your hip. Is that true?
Absolutely. In the hip, there's a lot of crossover of different causes of pain, and some folks will report that their back hurts, and that could actually be from the hip or the hip socket where the arthritis is. A simple x-ray would help give some clarity to that issue, and whether or not it's coming from the low back or whether it's coming from the hip itself. Hip arthritis can also mimic as knee pain, thigh pain, groin pain, and pain in the buttock or the low back. There's just a lot of moving parts in those areas, and it's good to get an x-ray to determine whether or not or to see which region it's coming from.
And this is a question for both of our docs. How young of patients or athletes do each of you treat?
I treat any and all ages. I think from an athletic standpoint, nowadays kids are getting into the sports at a younger and younger age. So I think any and all ages we'd be happy to see. And if it's something that needs to go to Children's Hospital, we have good contacts there to get you into the right place.
Yeah, I would echo that sentiment. I think it's something that we kind of pride ourselves on with our orthopedic service in Dearborn. I think for a while that sometimes patients have always felt the need to go to straight to Cincinnati Children's or straight to kind of into Cincinnati. And both Dr. Auer and myself are comfortable handling kids. I mean, I had a fracture yesterday in a 2-year-old kid that comfortable dealing with. And then, as he said, athletes, you tend to get serious earlier and earlier on in their career, the single sport specialization. And with that tends to come kind of increased rate of overuse injuries. And so really any age, certainly happy to see it. And as he said, if it's something that gets a little bit more into the weeds or a little bit more complex, certainly have good connections that could get you out accordingly. But a lot of the stuff we can take care of here in Dearborn County without you having to travel.
All right, so a couple more questions. Reminder to just submit your questions and we'll answer them live. Colleen, this is for you. What can I expect in my physical therapy session and how long will I need to do therapy?
So for your expectations for each session, the first session will be an evaluative session where we assess your range of motion, strength, and your overall functional mobility. That eval session usually lasts about an hour because we also are initiating your home exercise program at that time. Your visits subsequent to that will range anywhere from 30 minutes to 45 and upwards to 60 minutes, depending on your presentation. You will be doing exercises, reviewing the home exercise program with your therapist. Sometimes modalities are used to help subside some of the postoperative discomfort. As far as the duration of your physical therapy, depends on your diagnosis. As I mentioned in the webinar, for total hip replacements that are elective, most of the time they don't require a lot of physical therapy. You know, they'll just do the home exercise program that we provide them postoperatively day one and just walk and have a follow-up with their surgeon. If their follow-up visit with the surgeon warrants physical therapy to be needed at that time, then they will go ahead and define that. We'll get them scheduled. For non-elective total hip replacements, those are those that may fall and fracture the hip, requiring a hip replacement. Those, along with total knee replacements, require about 4 to 6 weeks of therapy following the surgery. And for your total shoulder replacements, once therapy begins, we put them down for an average of 8 to 10 weeks of physical therapy postoperatively.
Thank you. So it looks like we don't have any additional questions at this time. So we're going to wrap up the question and answer period. Your feedback is very important to us. So please take a moment to fill out the survey that will appear on your screen when you exit the webinar. And a reminder, we did record this webinar, so if you want to refer back to this presentation at a later date, please visit stelizabeth.com/living without limits. And I'd like to thank everyone for attending tonight and joining us, and thank you to our presenters, and everyone have a great week.